Hey everyone, how you doing? So this is a first for us. We're going to we've got 100 people on and we should be live now. So if you're watching, can you confirm by putting into your chat box that you can see me and you can hear me? Can you do that? Great. Okay, we've got confirmation. So I'm Dr. Frisella, and I'm an orthopedic shoulder surgeon in St. Charles County, Missouri. Today we're going to talk about COVID-19. Great. Okay, so I'm getting some feedback. Awesome, and it looks like it's working. So I had a little concern about the technical part of this, but it looks like it's going well. I'm here with Jill George, and we're going to talk about COVID-19 pandemic, and we're going to talk about how that's going to affect our ability to treat orthopedic injuries and specifically orthopedic work injuries. So we're going to go ahead and get started here. It's 9:36. Hopefully everyone that's going to be on is on. It looks like we have looks like we're good. Okay, great. So really today's talk is going to focus on how we can take care of orthopedic injuries and specifically orthopedic work-related injuries during the time of this pandemic. From my perspective as an orthopedic surgeon and orthopedic upper extremity surgeon, how we're taking care of things like rotator cuff tears, fractures, and other orthopedic injuries. We're also going to talk about COVID-19, a little bit an overview, and I'm going to talk about it from what I would call an educated layperson. I am an MD. I went to medical school, but I am not an epidemiologist. I don't do public health. I'm not a pulmonologist. We're not going to talk about how we treat the viral illness itself, but how this pandemic is affecting our ability to treat orthopedic injuries. So, COVID-19 is the name for the illness. The virus itself is called SARS-CoV-2. And it's a coronavirus, which is a family of viruses that also can cause the common cold. In 2003, a different coronavirus caused the SARS outbreak in China, and that outbreak only killed about 80 people, so a very different sort of problem. We're all trying to determine how COVID-19 is going to affect our personal lives. We're already affected by our kids' schools being closed, the closure of the restriction of the ability to work and go to bars and restaurants. We're trying to make decisions about how to conduct ourselves in public. And we're also trying to make decisions about our businesses. And that's what I'm going to talk about when it comes to the totality of taking care of orthopedic injuries. How are we going to do that in the setting of this pandemic? How are things now? And how do I see things going in the future from the perspective of urgent cares, ERs, orthopedic surgery offices, and physical therapy, imaging, MRI, and surgery and post-surgical care. So really the big issues with taking care of work-related orthopedic injuries during this time are, number one, providing that care, providing good care for the injuries themselves, providing safe treatment. Safe treatment means we're creating an environment where we're not going to transmit the virus to our patients, we're not going to get them sick, and they're not going to come in and get us sick. So safety from the point of view of this COVID-19 pandemic. And then access to treatment. So as things close and we're able to change, are we going to see delays in treatment? Are we going to see difficulty in accessing treatment for patients that have orthopedic injuries? So we're going to talk about all of those things, and that's really going to be the focus of the talk. But I wanted to start with just my take as again, educated layperson on COVID-19. Like I said, COVID-19 is a family of viruses that are in the coronavirus family. Some of those viruses cause the common cold. COVID-19 is a brand new virus, so that means it's never been seen in humans before. It very likely was a virus that was present in an animal and then mutated so that it could infect humans, and then it jumped from animal to human, the so-called zoonotic virus. So what makes it special or scary, depending on how you look at it, there's no need to panic, but the reason that it's spreading so rapidly and causing such a problem is there are multiple reasons for that. One is that it's brand new. It's a novel virus. So no human has, well, now they have, but no human when it started had been exposed to it. So there's no immunity in the community. No one can be vaccinated for it. No one's been sick with it before, so they're immune to getting it again. So every single person is susceptible to getting it. Another factor or feature of the virus that's problematic is that it can be spread from asymptomatic people. And a lot of this data is evolving, but we are knowing more and more that a significant percentage of people who get infected and can infect other people don't have symptoms or have very mild symptoms. On the flip side of that, certain populations and certain people will get very ill with the virus and require hospitalization. And that's one of the big issues is, do we have the hospital capacity to take care of those very ill people? And then the best data seems to suggest that the virus has a much higher chance of causing you to be very ill or die. And the best estimates now are it's about 10 times more likely than the flu to cause significant illness or death, but that's especially true in older or vulnerable populations. So we're talking about patients that are people that are older than 60 or 80, or that have comorbid medical conditions like lung disease, heart disease, diabetes, etc. So, excuse me, the features of the virus are, it's not the flu, it's a new virus, there's no immunity, it spreads easily. There's a factor called the reproductive number. If you have it, how many people on average will you spread it to? And the best estimates now are that's somewhere between 2 and 4. Other data seems to suggest it might even be higher. Compared to the flu, where one person usually transmits it to 1 or 2, maybe 3 other people, this is probably more easily spread than the flu. Some people are carrying it and are not very symptomatic. They don't get very sick. And that is good in the sense that they're not very ill, but it's bad in the sense that they can easily spread it in the community without knowing it. And then also some people, often older patients or patients with other problems, get very ill and require hospitalization. And these are the things that make it worrisome, and these are things that I think you're all reading about, and clearly everyone's very focused on what is coronavirus and why is it causing these effects. My personal opinion, it's serious. We need to take it seriously. It is not the flu, and the measures that have been taken to try to mitigate its spread are probably appropriate to minimize the chance of overwhelming the healthcare system. At this point, we've seen the virus in almost every country in the world. And in the US, there are several areas that have very high numbers of cases. And that's basically the Seattle area, Kings County, the Bay Area and San Francisco, New York City. And then there are also clusters in Massachusetts, Louisiana, Florida, and New Jersey. Now, the good news is, if you look at the latest data, Missouri, where we are, has a fairly small number of cases, but you have to remember, that number of cases really reflects the number of tests we have rather than the number of people that are actually infected. So I'm looking at the latest data here, and Missouri at this point has 43 cases, but that represents a 30% increase from yesterday. So we're seeing a significant increase in the number of reported cases, which again, remember, only really reflects how many tests we have. It doesn't necessarily reflect how many people are out there in the community with the virus. So that's really a problem, is we don't know very well who has it because we don't have enough tests. Right now, guidelines in general recommend that you can get a test if you have a fever, you have respiratory symptoms. Okay, you might think, great, okay, we can get a test then. No, you also have to have traveled to an area with a high rate of having COVID-19, so that's Europe, or in the United States, those places that I mentioned, New York, Seattle, or the Bay Area, or Colorado. Colorado also has a cluster in the ski counties. So you have to have symptoms, you have to have a fever, You have to have traveled to an area that has a significant outbreak of COVID-19. And on top of that, you have to have a doctor's order. So the number of tests that are being done is fairly limited at this point, and it's a big issue in terms of knowing what is actually going on, who actually has the virus. But I will say that although Missouri, where we are, has been spared, the number of cases has increased 30% every day for the last several days, and likely is going to continue. So I don't think Missouri is going to be spared, but clearly Missouri is not one of the quote hot spots, and that's a bright spot for us for right now. So the question is, what does the future hold? And really no one knows that, but in my opinion, and I think the consensus among public health experts and the epidemiology community is it's clearly going to get much worse, in the sense that many, many more patients are going to be infected. And the point of these mitigation strategies, the point of keeping people at home, avoiding outside contact, avoiding going to bars and restaurants, avoiding big groups of people, is to try to minimize the number of people that get it all at once. Because the problem is, if everyone gets it all at once, it's highly transmissible, it's highly contagious, and if we see a big spike or peak in cases, it could potentially overwhelm the capacity of the hospital systems to take care of people with severe respiratory illness. So that's COVID-19. That's something you probably all have read or heard. I think all I can do when I add my voice to that question or to that issue is to say that I do personally take it seriously. I don't think it's an overreaction, and I think that these measures are necessary. So if you think about what does that mean for us taking care of orthopedic injuries? So in St. Louis, in Missouri, in the Metro East of Illinois, how is this going to impact our ability to take care of work-related injuries and other orthopedic injuries? So you see a patient, or you get the call, you're an adjuster, you're a nurse case manager, you're an employer, and your employee falls off a ladder. They're doing maintenance and they fall. They're in a car accident. First of all, I would just say that right now, except for surgery, it's basically business as usual. So urgent cares, emergency rooms, occupational health offices, orthopedic offices, MRI, physical therapy. At this time, all of those entities, the entities that are taking care of orthopedic injuries and orthopedic work injuries, are open. They're seeing patients. They're not limiting patients, but they're business as usual with precautions. So all of those entities, and I've talked to the owners or directors of the therapy, of various therapy companies, of the radiology companies, of the urgent cares, the occupational health clinics, and other orthopedic offices, as well as the entities that do surgery, or ASCs. And right now, it's business as usual with precautions. So if you have an injured worker right now, you can basically treat them how you always have. There's nothing extra that you need to do. I would add that if you're the one taking the call, or you're the one first evaluating a patient that has an orthopedic work injury, it's probably a reasonable idea just to ask them the simple question of, do they feel ill or sick? Do they have a fever? Do you feel sick? And you don't need to do anything with that piece of information except pass it on to the healthcare provider that they're going to go to next. Every single office, every therapy office, every urgent care, every occupational health office, and I've talked to all of these people, have protocols in place to screen patients for international travel, travel to hotspots, and respiratory symptoms. So they're going to be screening those patients. They're going to be making decisions based on the answer to those questions, about those questions. But if you can go to them and already know that, this patient has an injury, but they are also telling me that they're sick, that is a useful piece of information. It's probably reasonable to ask that question, that simple question, when you're going forward with the process of getting them care. So again, when we're talking about how do we treat orthopedic injuries in this pandemic, right now it's pretty much business as usual, except with the exception of a surgery. And we're going to talk a lot about where we are with doing a surgery on orthopedic injuries, because that's changing significantly. But at this time, you can really, if you have an injury today, there's no change in how they're being treated except for additional screening and additional precautions. I'll talk about what most offices are doing and what our office is doing. So let's talk about urgent care. I've talked to the owners or directors of several local urgent cares and occupational health offices. They have no plans to close offices or reduce services. They don't anticipate any regulatory changes from the state or federal government that would reduce the number of offices or force them to close. And they are taking precautions to minimize the chance of spreading COVID-19 between patients or between providers and patients. It seems unlikely that there would be any regulatory action to have urgent cares or occupational health offices close, but there's also always the risk that employees at those offices test positive for COVID-19, especially as we have more and more tests available and we're able to test more people, and that might affect office closures. We'll talk a little bit more about that later because I'm going to talk about what might you see change, what might be barriers to getting patients taken care of. Really, the changes that we might see really boil down to, could we be forced to close, any of these entities be forced to close, or could employees of these entities get coronavirus and have to close because of that? Forced to close because the state or the federal government says that we need to close, or forced to close because their employees test positive and we can't be open because that would risk transmitting the virus to patients. When you talk about urgent cares, they're still open. When you talk about the emergency room, it's still appropriate, as it always has been, for high energy injuries to go to the emergency room. So if you're a patient that, you have a claimant or patient employee that falls off a ladder and they have a significant injury, the ERs are always going to be able to take care of those patients. I would say that as the ERs gear up to see and treat a high volume of respiratory illness, and that's exactly what they're doing right now, it is possible that you're going to see delays in treatment. It's possible that you're going to see patients waiting for a long time and not being able to take care of right away if that particular ER is overwhelmed with respiratory illness. Now, that may not happen, may never happen, but that is a possibility. That being said, the ERs are always the right place to go if there's a high energy or significant injury. And if patients need emergent surgery, that's going to be available through hospitals for significant severe injuries. We're talking people with femur fractures, with head injuries, things that are, car accident level stuff. Now, the average work injury where someone reaches out and they have a strain or a sprain, they're going to therapy, or they fall and twist their ankle or wrench their back, that's clearly not generally going to go through an ER anyway, and that's a different entity. We're talking about high energy stuff here. Now, when we think about private practice orthopedists, so most patients go through a process where they're being seen in an urgent care, an occupational health clinic, and they're not getting better, and so they're referred to orthopedic offices for evaluation, maybe after they get an MRI or they're failing conservative treatment because they're not getting better with therapy or injections or medicines. So right now, orthopedic offices are also what I would say is business as usual with precautions. What's my office doing? So we're screening patients. So we're asking them about their travel history and their symptoms. We are asking them to not bring in extra family members. We're asking them not to bring family members back to the ER. And we're asking them not to bring family members back to the, excuse me for a second. We're asking them not to bring family members back to the waiting room. We're doing increased cleaning. We're wearing barrier protection when necessary. We're asking patients to wear barrier protection when necessary. And so those are the things we're doing to minimize the chance of spreading the virus within our office. But it is still business as usual. Patients who need to be seen can be seen. Now, we are implementing some telehealth solutions. In other words, the federal government has actually relaxed rules about using video conferencing for seeing patients, and we're doing that now. We're implementing that. So potentially patients could be seen by telehealth. So they call in and we talk to them over FaceTime or Skype or other platforms that allow video conferencing. And that may be something that we implement more, but especially for post-op visits and other visits where it's really not as important to perform a significant physical exam. But you may see that happening through orthopedic offices where you're getting telehealth visits where there's a documented note with a basic physical exam that can be done through video, and that's going into the patient's chart and it's counting as a note, but they're not actually coming into the office. And that may be something you see with physical therapy as well. So moving on to physical therapy, what are we seeing there? What we're seeing with physical therapy is that right now, again, like everything except surgery, right now, it's pretty much business as usual with precautions. Therapy offices are also screening patients, taking their temperature, asking about their symptoms, asking about travel history, but they are seeing the patients as they normally do. Now, there has been some talk in other states. Ohio is what has been specifically mentioned about potentially closing therapy as non-essential. You have to, it is true that therapy is very high touch. Most orthopedic injuries, patients are going to therapy 2 or 3 times a week, so they're being seen quite often. And that does represent, just like any interaction represents a risk of transmission. So when it comes to therapy, there is a chance of a regulatory change or a mandated change in therapy where therapy is shut down. Now, at this point, there's absolutely no, at this point, that's absolutely not the case. But, thinking about what could happen, that's certainly in the realm of possibility because surgery has already been significantly affected. And before we talk about surgery, we're going to talk about MRI and imaging. So at this point, when I speak with my radiology colleagues, there is no, again, it's business as usual with precautions. If you need an MRI, you can get an MRI. You need to realize that MRIs are also necessary for potentially life-threatening problems, brain tumors, aneurysms, strokes, things like that. So the MRI scanners aren't going to be shut down. And I don't anticipate seeing an inability to get MRIs, especially since it's really not a high interaction sort of test. You're not face to face with someone. You're in a scanner. It can be cleaned, so that shouldn't change that much. And I don't see that changing. Now it brings us on to surgery. So I'm trying to just go through the gamut of things that happen when you have an orthopedic injury, from urgent care, occupational health, orthopedics, physical therapy, MRI, and then surgery. So surgery is changing. At this time, a couple of facts. So one, in St. Louis, the major health systems, that's SSM, Mercy, BJC, St. Luke's, have entirely stopped elective procedures. What is an elective procedure? Right now, that's really defined as someone, a problem that if you wait 8 weeks, it's really not going to affect the outcome of the surgery. So fractures, significant and obvious tendon tears, things like head injuries, those things can still have surgery. That we're going to continue to do surgery for those problems. But elective surgeries, so from orthopedics, more obviously, that's things like joint replacements. That's things like cosmetic procedures. Those things are not going to be allowed anymore. You can't go and get your knee replaced. You can't go and have your tummy tucked. Those things are on hold for now. What it means for in between problems like chronic rotator cuff tears, meniscal tears, it's a little bit unclear right now. Now, that being said, that's the hospitals. Right now in the state of Missouri, ambulatory surgery centers where probably 95% of orthopedic injuries are treated, maybe 90%, of less acute orthopedic injuries are treated, they are still open and they are still doing business for any and all elective procedures. That probably will change. In Ohio, all ASCs have been shut down for elective procedures. And right now, the question in Missouri is, will that happen? And if it does, what is the definition of an elective procedure? And that's where you might start to see delays in treatment. You might see injured workers who have been injured, but it's going to take them a lot longer to get to surgery, or they may be on a fairly significant delay. And the question is going to be probably for most ASCs a judgment call as to, if we wait too long to do this, is it going to change outcome? So my perception, if this were to happen in ambulatory surgery centers, we would still probably be operating on patients with entities like ACL tears, acute rotator cuff tears. They just fell a week or two ago. They have a big tear on the MRI. If we wait too long, maybe we can't get as good of an outcome. That probably would still be something we're going to do surgery for. But problems like carpal tunnel release, tennis elbow release, other surgeries that are probably the outcome isn't going to matter so much if we do it now, or we do it 8 weeks from now, you may really start to see delays in that type of surgery. And I can't see the future, but I think that as the number of cases is going to increase, which it is going to increase in Missouri and specifically for me in the St. Louis area, I think it's likely that we're going to see a change in our ability to do the most elective procedures, even in ambulatory surgery centers. Right now, there's no change, but that could certainly change, and my belief is that it probably will. So just breaking then, what won't change? Probably what's not going to change is urgent cares, ERs are going to be open, they're going to be seeing patients, they're going to be doing extra screening, but you can continue to send patients to those entities. There's a chance that some offices are going to close from quarantine, and I think that's the other big issue. So no matter if the state or federal government, they're not going to probably, I think very unlikely that they're going to shut down healthcare offices. So doctors' offices, urgent cares, ERs, I mean, almost unthinkable. But if a specific doctor's office has 2 or 3 employees that have tested positive for COVID-19, it is certainly possible that that office is going to close temporarily, that those patients, those people, those employees will be quarantined, and that since they've been interacting with these employees, those employees will be quarantined too. So even though I don't see a regulatory risk for the federal or state government or local governments shutting down doctors' offices or healthcare provider offices, it is certainly possible that specific offices will close or have trouble providing care if they're forced to quarantine because of positive patients or cases in their business. So what's not going to change? You're still going to, urgent cares and ERs are going to be open. Orthopedic offices are going to be open, again, with that caveat that maybe they might close if there are positive cases. Another change you're probably going to see is telemedicine. That's already happening very quickly. All orthopedic offices, our own included, are implementing telemedicine options for patients. So what does that mean for you if you're, say, an adjuster who has a patient that's very reluctant to go to the doctor, or is having a problem? You're having a problem with them because you're saying you need to go. The doctor's office is open. They're saying, I don't want to go. I don't want to be out in public. They're afraid. That's someone you can call an orthopedic office and ask, have you implemented telemedicine? Could you see this patient via telemedicine? And I will tell you, I think every single office is probably going to have that option and be able to see patients with a video interface. The nice thing about what the administration on the federal level has done is they basically suspended HIPAA. So you don't have to worry about all the secure things. You can just basically call the patient up on FaceTime, Skype, and talk to them and document that in the note. You may also be getting bills. You'll be seeing bills for telemedicine visits. And I think that's definitely something you're going to see over the next couple of weeks, because we want to be able to take care of people. We want to do it safely. We want to minimize the chance that patients are bringing COVID-19 into our offices. We want to minimize the chance that those we're giving it to the patients, and telemedicine is one way to do that. We talked about this, but the big change may be surgery and delays from surgery, but urgent and emergent problems will still be able to have surgery in hospitals or surgery centers, and that will likely never change. I also would say that there is a chance that we start to see supply chain issues for surgery centers. That I'm already seeing that some where there's been delays in supplies we need to do surgery. It's nothing that is preventing us from doing surgery now, but if supplies become a huge issue where we're having trouble getting masks, things like that, that might be another reason why surgeries are delayed. And so of all the parts of taking care of orthopedic injuries in the context of this pandemic, the ability to do surgery, I think, is going to be the one that's most impacted. The second, I think, is probably access to ERs. And the third that may be, in fact, impacted is access to physical therapy. So when you talk about the most impacted, which would be surgery, I think there are two main questions. One, are they going to shut down elective cases? And two, well, maybe three. Two is, what is elective exactly and what isn't? And that's going to be a judgment call. And then three, are we seeing that we are having so much trouble getting supplies that we can't do surgery? Now, none of that is true now, right? At this moment in Missouri, we can do surgery just like we always did, but with precautions. I do see that being the most likely to change in the next week or two. And one other point with surgery is that it's possible that it's arthroscopy, in other words, rotator cuff repair, knee, meniscal surgery, those kinds of things are defined as elective just across the board. That's possible. So if that were to happen and the ambulatory surgery centers, the place where we do most of our surgery, were to say, you can't do arthroscopy, I think that would probably affect a huge percentage of the orthopedic work injuries and really just generally the orthopedic injuries that we're doing surgery for. So I think that just when you think about how is this going to affect orthopedic injuries and your claimant with an orthopedic work injury, the biggest issues are probably going to be if they need surgery, is that going to end up being delayed and they're on restrictions for longer? The second biggest issue is, are you able to get them into the office you need because that office has closed because they're forced to quarantine? Again, not something we're seeing now, but looking to the future may be something we see. And then third would be are we seeing supply chain issues so that surgery isn't possible? So I'll just do an overview of what we talked about, and then I'll open it up to the chat questions. We'll start with COVID-19. My opinion, educated layperson, it is real. This isn't overblown. We need to be doing these things, even though they're having a gigantic and negative impact on the economy and lots of people's lives, including our own. I mean, orthopedic practices are being significantly affected by this because we can't do the surgeries we're normally doing. I think mitigation measures will continue. So limiting the ability to go out, limiting the number gatherings, and those will probably get more significant in Missouri over the next week or two. Missouri has been one of the states that has actually done the least in terms of limiting movement, gatherings, etc. But as we start to see cases increase, which they've been increasing about 30% a day over the last couple of days, I think you're going to see a lot more of that. I don't think that's going to go away. And then it's just going to depend on how the cases go. Typical services for injured workers as it stands today are essentially unchanged, urgent care, or occupational medicine, orthopedics, ERs, therapy, MRI, and surgery can all be done right now. But again, the biggest potential changes would, I think, in order of likelihood, be surgery, followed by physical therapy, in terms of there being some entity says, no, you just can't do that anymore. And then, that's basically what I have to say. I guess the one thing you might think about if you're in the trenches treating orthopedic injuries, or you're adjuster, nurse case manager, attorney dealing with a litigated claim, is that if you have a preferred provider for therapy, MRI, orthopedist, you might think about a backup, because if that office is forced to close because they have literally been had an employee or with coronavirus or with COVID-19 that has been infected and potentially infected others, they might not be able to see patients in that office anymore. And so having a backup is a reasonable thing. So I'm going to stop there. It's 10:11, and if you have questions, you can type them into the chat. I think Jill has been writing some down, and I'll try to answer them as best I can and go from there. Got anything? Oh, so I'm just waiting to see if anybody has any questions. Sorry. Sure. So Jill has a question.
So how are employers feeling about keeping people on longer restrictions, based, if they can't have surgery that's needed and bump things up?
Well, so Jill asked, how are employers going to feel about keeping patients on restrictions for longer if they can't have surgery? And I mean, I can't answer how the employer will feel, but I do think that it's going to be something you're going to see. And I also am interested in if any of you who are watching have what you're seeing out there, if you're an employer or a nurse case manager or a adjuster, attorney, have you been seeing any changes in what's going on with claimants? Well, all right. Well, if no one has any, oh, we go.
Increased scrutiny.
Good question. So we're getting a question that is there increased scrutiny of claimed injuries from a medical care provider's perspective? And this is a comment I actually made just yesterday, is that I can, in times of economic turmoil, you do see, my experience, you guys probably know better, see an uptick in patients who are claiming injuries because they're losing their job, because there's uncertainty economically, because they perceive economic threats. So there, are some questionable injuries. So, the question of compensability and credibility, and is this a legitimate injury, certainly still apply just as equally as they always have. And I would anticipate, and I was just saying this the other day, an increase in, IMEs about causation, in employers who are, basically concerned about the compensability of an injury. And the assessment of compensability and causation is always a part of our initial evaluation. And I personally appreciate it if you're going to send me a patient where that's a significant question, let me know, because that helps me do a complete evaluation of that question of causation, which again is a typical part of what we do. But I would say that I think there was going to be maybe an increase in questionable claims because people are worried and scared and want to have some insurance about income, basically. So there's another question from Kevin at SSM Physical Therapy. If we go to telehealth, how do you want us communicating with therapy? I wouldn't, if therapy is being done by telehealth, I don't see there being a big difference in how we want that communicated. I mean, a therapy note prior to the patient's visit or at the time of the patient's visit where we get a sense of where they are in therapy wouldn't change for me. Another question that I haven't talked about is, as the physician, are we going to continue to order therapy the same way? Are we going to decrease the numbers of therapy visits or ask for telehealth therapy visits? I would say at this point for us, we're not planning on doing that, but it is certainly something I'm considering. When you think of all the parts of caring for orthopedic patients, the biggest, face-to-face touch interaction is with therapy. And I think it's probably represents the bigger risk in terms of viral transmission is when you're having these very close face-to-face interactions and doing the therapy. So number one, I think that's why it's a slightly increased risk for being shut down from the state or federal perspective, but also just from a safety perspective, it's something where decreasing the number of visits, going to more telehealth, going to more home-based therapy might be reasonable as we see an increase in the number of cases. All right. So there's still 43 people on. And if you're one of those people, ask a question. I'll give it, a couple more minutes. I can just speak, I guess, to the, generally how we're experiencing it in our practice is that we're seeing a decrease in the number of patients that just come in for general pain complaints. And we're also seeing that we can't do elective procedures anymore. So the issue for us is being able to provide care for patients, to take care of them, to see them if they need to, but to do that in a safe way. And that's going to be the challenge of the next couple of weeks, to continue to help people with orthopedic problems while minimizing any impact that has on this pandemic as it progresses. Well, anyway, I'm going to then wrap up. I'm not seeing any other questions, and appreciate everyone tuning in. There's, if you have anything, you can always email us, email me, drfrisella@gmail.com, or you can comment on the video. The video will be up in my YouTube channel, and I appreciate everybody tuning in, but I'm going to go ahead and end then. All right. Thanks, everybody.